Thanks very much, Will. Rather than an update, I'm going to muse about an approach to surveillance guidelines. I'm going to concentrate I'm going to ignore inflammatory bowel disease and dysplasia. I'm just going to concentrate on post-colorectal cancer resection, which is pretty straightforward, and then compare and contrast the Australian guidelines, which I think are unjustifiably complicated and complex, and mention the British and US guidelines.
So while we're musing this, Cameron, we will are you taking responsibility, accountability for the unjustifiably complex surveillance guidelines that we now have?
Oh, look, I guess like a Prime Minister whose ministers are misbehaving, I suppose I have to. I'm not going to fall on my sword over it. I desperately tried to talk the chapter leads around to my point of view, but I failed, unfortunately. So, but I don't think they're a complete waste of time, but unfortunately there's the complication that they were then used to link to MBS item numbers, which I'm not even going to touch on. So basically we might start on the easy bit while we're sorting out, and I apologise that I'm not an Apple sort of person. So the colorectal cancer guideline is basically if you've crossed the cancer and done a complete colonoscopy before resection.
Cam, Mitch is here talking.
So after a curative resection for colorectal cancer, the colon should be examined completely before or within 6 months of surgery, the latter in the case of an obstructing cancer where the unexamined proximal colon wasn't resected with the cancer. The subsequent colonoscopy should be at 1 year, and then every 3 to 5 years according to polyp findings as per the polyp surveillance guidelines. So that's pretty straightforward, although it's very common in my experience for post-cancer resection patients to end up with annual colonoscopies, which is not something that the literature would bear out. So most of the time I'm going to talk about surveillance after resecting conventional adenomas or clinically significant serrated polyps. And I'm going to spend most of my time musing because I've thought an awful lot about this. So the problems facing analysis of the literature, or those charged with analysing the literature and generating surveillance guidelines, are that these are old studies, they're using old scopes and old colonoscopist behaviours. To my mind, that almost makes the literature uninterpretable. And if you read the British or the Australian or the US guidelines, many of the recommendations are low evidence, low confidence. So weak evidence, low confidence in making a recommendation. And when you consider the proportion of our colonoscopy burden that's taken up with surveillance, it's a substantial issue. And they're old studies because they need a certain amount of follow-up to work out what the consequence of having 1 or 2 small adenomas or 3 or 4 adenomas and mixed in with some sessile serrated lesions are. So translating those results into 2023 expectations of high quality colonoscopy is difficult, and you have to remember that built into these guidelines, polyps, we know that polyps can be missed or incompletely resected. So the final thing is that they're generally an extrapolation from unplanned observational cohort studies rather than planned follow-up intervals. And one of the areas that's crying out for research is to compare a surveillance strategy after initial findings versus no surveillance, because there is mounting evidence that it's the first colonoscopy in a patient's lifetime that has the most impact on reducing the risk of colorectal cancer. And if I were a dictator, I would only let high ADR colonoscopists do people's first colonoscopies, but I'm not. So theoretically, once the colon's cleared, the next scope should take place at a Goldilocks interval. It's not too late before a new polyp becomes a cancer, and it's not too early because there's little point just removing low-risk diminutive adenomas, the vast majority of which, I keep telling my registrars, are never going to turn into anything in the patient's lifetime. Considering that good ADR colonoscopists find polyps in 50 to 60% of people, and only 5 or 6% of people are ever going to get colorectal cancer, it just makes that point that the vast majority of the numerous polyps we cut off were never going to do anything. We just don't know which ones would have and which ones wouldn't. And you ideally want to find and remove endoscopically manageable advanced polyps in a significant proportion of the surveilled population. So we'll get onto the Australian guidelines, but I'm not going to spend a huge amount of time on them, and I'm not aware of any plan from Cancer Council Australia to revise them anytime soon. So the standard nomenclature is of low-risk adenomas, meaning only 1 or 2. They're small, so they're less than 10 millimetres, and they don't have high-grade dysplasia or velocity. High-risk adenoma is basically any other conventional adenoma, more than 2, and with any of those other features of an advanced status. And this is the only table, the only colour-coded table that I'll spend any time talking about. You would all have this on the wall of your endoscopy units. So let's talk about low-risk findings. So that's these. So 1 to 4 adenomas less than 10 millimetres without high grade or velocity. And the 3 to 4 number used to attract a 3-year interval in the 2011 version, and the 1 to 2 used to attract a 5-year. Now, there is plentiful evidence that if you have 1 or 2 conventional adenomas only, and they're without any high-risk features, that having those found and removed at colonoscopy, you are then at below average population risk for subsequent colorectal cancer. And there was a strong push in the working group to return these people to FOB testing. I might just move on there, but just one sort of observation that subsequent to those guidelines, the New Hampshire group suggested, with a reasonable amount of evidence, that diminutive and small conventional adenomas, so those essentially above and below 5 millimetres, may have different significance. And I think a lot of US colonoscopists take this into account, and instead of doing it at 10 years if they're both diminutive, do it at 5 years if they're both small. So high risk findings without multiplicity is the rest of those first 2 lines on the table, and you can see that that's either the high risk is either because the polyps removed have high-grade or villous changes, or that they're then a mixture of a couple of things. And the riskiest polyps and the ones for whom earliest surveillance is recommended are those with at least one of the adenomas being more than 10 millimetres in size, with high-grade and with villous change. Now, the impacts of those 3 things are difficult to tease out because they interact with each other, and the presence of 2 or more of those 3 factors probably confers greater significance to colonoscopic findings. And it's interesting that the Brits don't rate velocity at all. They've taken it out of their equation, largely because of variation amongst pathologists. Multiplicity, which is the bottom 2 lines of the original table, suggests that there's a possible field defect or a polyposis syndrome, and it increases the increased spectre of having missed something at your initial scope. So essentially, unless you're very lucky, you score a 1-year colonoscopy. Now, my biggest problem with the 2019 guidelines was the serrated polyp follow-up, which was touted by the chapter authors as being groundbreaking. I'm not going to concentrate on this because really I'm not going to concentrate on this slide because I don't want to get into that. But all of the sessile serrated lesion surveillance problems rely on 3 studies. They were graded level 2 or 3 evidence, and they were felt to be of low quality. They were more than 10 years old. Well, they're now more than 10 years old. And my big problem with them was that the SSA detection rate was, as it was called at that time, was lower than 5%. Now, I'm not going to embarrass the audience by asking you to tell me what your SSA detection rate is, but we know that in elite hands it should be up around 15 to 20%. So what these studies were identifying was what was happening to the 3/4 of SSAs that they were missing. And to then base a whole series of complex tables of SSAs only, SSAs with adenomas, and then second and third surveillance recommendations on such flimsy evidence strikes me as being unjustifiable. I don't mean to sound too harsh, but you know, we've been burdened because of the MBS issue with trying to rely on this stuff, and I just don't think we can rely on it. I'm going to skip to a colour diagram that I think reflects that situation. So this is the first surveillance if you only have cess-ulcerated lesions. That's pretty straightforward, and it's probably not unrealistic. But then to get to this degree of complexity and try to convince me that any one of those 16 squares on the diagram has enough evidence to justify applying it to at a national level, I'm not that gullible. Let alone this. I don't even know what the hell this means. I have looked at this and
You drew this up?
fair to say it wasn't me. This time it really wasn't me, like the farmyard cat in trouble. Now, and this. So this is the, This is the colour diagram that I think reflects this situation. And when I was preparing this talk, I was reading to my 3-year-old, and I thought the Cat in the Hat had it all just about summed up. So I'll move on quickly to finish off. The larger neoplastic polyp surveillance is largely based, I think, on Michael and the Westmead's opinion that en bloc resection be looked at again in 12 months and piecemeal at 6 and then 18. The multi-society, the US multi-society task force guidelines, which came out a year later than the Australian ones, are reasonably parallel but much simpler in terms of the first surveillance interval. If you look at this, and I'm happy to have the slides shared, etc., you can come and get a copy from me afterwards. It parallels pretty similar. It parallels pretty closely the Australian guidelines. So they, for example, recommend 7 to 10, not 5 to 10, for 1 or 2 low-risk adenomas. And their first surveillance guidelines are very similar regardless of what your baseline finding was. So on the uncircled side of the diagram, it doesn't really matter whether you had 1 or 2 tubular adenomas, 3 or 4, or advanced adenomas, you ended up with a similar surveillance recommendation. And I think if you're going to apply, you're going to get beyond first surveillance, I think something like this is necessary. Now, this is the British version, and I think this is my last slide, Raj. I'll get out of the way in a minute. But I wondered whether Boris Johnson was involved in generating these, because they are very, very nihilist. And by comparison with Australia, where we perform 1 million scopes a year, head per head, the Brits do 38% of that, and largely it's because they don't do nearly as much surveillance. So the only bit of this that refers to adenomas and cess-ulcerated lesions is the third green diamond in. So over on the left-hand side is colorectal cancer. The next diamond in is large non-pedunculated polyps. Then there's the bit that refers to adenomas and their high-risk findings, which are really just more than 10 millimetres or high grade. And if your initial findings are high risk, then you have a one-off surveillance colonoscopy at 3 years. And if you're not, you bugger off back to the fecal occult blood testing program. So if you look at the people involved in generating the US, the UK, the Australian guidelines, they're all experts. And one of the things that makes me suspicious about this is the fact that they can all be looking at the same literature and come up with such vastly different opinions. So this is my last slide, I think. I think in future we need a different approach to surveillance guidelines that should probably also incorporate operator stratification according to ADR and SSLDR. And it should also take into account polyp biology. You know, we're all familiar with the phrase polyp cancer sequence, and no one can actually tell me what that is, whether it's a thing that if an adenoma it turns into a cancer, whether it's going to take 5 or 10 or 10 to 15 or even longer. But as far as I'm aware, the only polyps that have a more rapid pathway through that sequence are Lynch polyps and some polyps in serrated polyposis, maybe SSLDs, but maybe patients who develop velocity or high-grade dysplasia in a small lesion. I think this is the way that future guidelines are going to have to be generated. And I'll stop there, Raj. Thank you.
Thank you for that excellent overview, Cameron. We have time for one question one question.
So what should we be following now, Cameron?
It's a very, I reckon the 2011 guidelines were much closer to the mark. And I think the next revision of those guidelines, and I'm not aware there's any funding or any intention at the moment, but I think that needs to be, that we need to sort of bear in mind the fact that expert groups come up with quite different. And I think the big hole is what to do with SSLs. Generally, you know, just the feel from reading all those guidelines carefully is that SSLs of the same shape, the same size, probably carry a slightly more weight than a conventional adenoma. But we also know from the work from southeast Queensland that many people have SSLs in their bowel for 17 years and nothing happens. Thanks.